My name is Haley. I'm currently the president of EMBS here at UIC. So today it's going to be our second distinguished lecture event of the year. We have the privilege of hosting Dr. Nimmi Ramanujam. And then before I let Derek get into who Dr. Ramanujam is, how she got to this point in her life, and Derek, by the way, is the sole person that puts together this event, which is why we're all gathered here today. I just wanted to briefly talk about who EMBS is at UIC. So EMBS stands for Engineering in Medicine Biology Society. We are a neural engineering, bioinformatics type society within the general scope of biomedical engineering. We do a lot of workshops, special types of event. We have an event coming up Saturday, April 9th with EWH. We're going to go to Lincoln Park Zoo. Past workshops have looked like Intro to Python, Intro to Java. We just had an Intro to Machine Learning with Dr. Yee. So if you want to stay on top of things going on in the society, I'll throw some links into the chat. You can add our calendar to your Google Calendar, and then you can also subscribe to our mailing list, and you just kind of get priority notifications of everything that's going to be happening. But yeah, that's pretty much all I just really wanted to talk about. I'm going to let you take it from here, Derek.
So if everyone can hear me, that's great. But I would like to give a warm welcome to our first IEEE event of the spring semester. So my name is Derek Joseph. I am the Distinguished Lecturer Outreach Chair for EMBS here at UIC, and I'm focusing on cell and tissue engineering with my degree. And I would like to first start off by welcoming our distinguished lecturer for today's event. Her name is Dr. Nimmi Ramanujam, and she earned her PhD from the University of Texas at Austin in biomedical engineering. And she is currently working as a Robert W. Carr Professor of Biomedical Engineering, and she's also a Professor of Cancer Pharmacology and Global Health at Duke University. And one of the most amazing things that she's done in her time at Duke is also found the Global Women's Health Technologies, which aims to provide accessible healthcare and technologies for women across the globe. And she is very well known for inventing out-pocket colposcope, pioneering cancer screening technology, and she is well known for founding the companies Xenolox and Cala Health. And she has spent her last 2 decades working hard to develop these products to address global health disparities. And hopefully what you get out of today's talk is just seeing how her patient-centered solutions for global cancer applications can be helpful in her organizations, and how biomedical engineering can assist with addressing these disparities. So just before we begin our talk, I would like to make sure I cover a few housekeeping rules. So please keep your microphones muted throughout the presentation. There will be a time at the end for questions. Either I or Haley can help broadcast those questions in the chat. So we appreciate it if you guys had proper etiquette throughout the call. And we will also record this video as of right now and post it on our YouTube channel. So for those of you who just joined in or weren't able to see part of the lecture, you can now see it in full time. And we will be able to present the YouTube video hopefully by the end of the week or in the coming weeks during the semester. And yeah, we just ask that you guys are professional at all times. And that's all I have regarding the introduction. So I did enable host privileges for Dr. Ramanujam. So whenever you're ready, you can begin your lecture.
Thank you, Derek. Thank you, Haley. I actually cannot share my screen yet. It says you cannot start screen share while other participants are sharing.
I just have to stop sharing my screen. So let me do that right now.
Okay, great. Thank you.
Of course.
Let's see. Where am I? Great. Well, thanks again for having me give a talk today. So as Derek mentioned, my center is really committed to developing global health technologies with the idea of being able to solve global inequities, but also to think about how we can accelerate the impact of those biomedical innovations. And I will specifically talk about cervical cancer prevention as one of our target applications. But I also wanted to add that we're very interested in sustainability and empowerment. So we're also, in addition to training our PhD students and undergrads, we also have a program called Ignite, where our undergraduate students basically learn about technologies in their courses and then create curricula which they then use to mentor students both locally and globally. And we have a program in Guatemala in collaboration with one of my former students. And basically they're reaching about, have reached about 2,000 students through their program and scaled through Guatemala. So we're very excited. And I just wanted to throw that out for undergraduates who are interested in sharing curricula or participating in Ignite. So I wanted to provide some context for our current interests in global health. And this graph basically provides a snapshot of the strides that were made towards the Millennium Development Goals, which essentially was a way to declare that there are tremendous disparities globally and to meet some milestones over the course of the next 20 years, and this was, or 15 years, and this was, I think, established in 2005. And you can see that there are middle and low-income countries shown here. And basically what this graph shows is the acceleration ratio. So how much progress has been made and the share of the problem eliminated. And obviously, any number over 1 is good. And so what you can see is that the major strides were really made in low-income countries as a result of the MDGs. And we really saw great dividends in child and maternal mortality. So the instrumental tool for reducing global mortality in children under 5 years was the ability to disseminate vaccines that have proven very impactful in high-income countries. And you can see that over a course of 20 years, there was a significant reduction in the number of deaths, and the total overall lives saved was about 36 million over the 20-year period. And so the question is, what's next? Clearly, this problem isn't completely eliminated, but there are problems that keep arising that we have to consider as engineers and individuals committed to global health. So in the last 100 years, really the challenges globally were communicable diseases. And there has been significant progress in that area. And as we see communicable diseases and injuries go down, communicable diseases go down, we're actually seeing an increase in non-communicable diseases. And specifically with respect to cancer, there is an increase in the predicted global cancer cases. And you can see that the rate at which it's expected to increase is highest for less developed countries or developing countries. So let's briefly review global deaths due to NCDs. And you can see that from 1990 to 2010, the greatest increase has been in cardiovascular disease and in cancer. And so there are well-established solutions for CVDs that have worked really effectively in high-income countries, many of them being, preventative medication, for example, and lifestyle. But we know that with cancer, there are many solutions and treatment options for early cancer. But for advanced cancer, whether you're in a high-income or low-income country, you still have similar challenges in that advanced cancers are always challenging to treat. So with the limited resources that you have in low and middle income countries, the key is to focus on prevention, because though the treatment options are few for patients with advanced cancer, there are few resources to even address that issue in LMICs. So over the last 100 years, in countries like the US, we have made significant strides in the way we see and treat disease, and in particular cancer. And about 100 years ago, one would think about disease in the context of what I would call intuitive medicine. So for example, if somebody presented with a symptom like a cough, it would be unclear whether that's just a respiratory infection or whether it's lung cancer. And with the advent of technologies, we're essentially being able to go from intuitive medicine to greater specificity, and that allows us to differentially diagnose disease and hence be able to offer the appropriate treatment. This is a picture from my colleague taken in Ethiopia in a hospital, and this is in stark contrast to what is available in high-income countries. And we all know that one of the ways this issue is addressed by donating equipment. However, many of these donated pieces of equipment are hardly used and in fact take up premium real estate. So there needs to be an opportunity to address this problem. And I think that engineers are really well suited to do that effectively. The other important piece that I should mention is that we're at a point in time where we do have solutions that can address the gaps in being able to institute infrastructure and human resources to support the more sophisticated equipment that I showed earlier. However, there are opportunities to do equivalent or at least comparable approaches to diagnosis using point of care technologies, whether it's antibody testing or looking at cells or tissues inside the body, or minimally invasive treatment, for example, ablation. So there are many possibilities, and one of the opportunities is to think about both how to develop these technologies, but also how to disseminate them in a human-centered way in the appropriate settings. And I just want to say that's a pretty daunting task. Sometimes it's easier to develop the technology than actually get it to the end user. So it's just something to keep in mind. Now, what I'd like to do is illustrate that possibility through one example. And since we work on cervical cancer, I'd like to specifically focus on that. Now, it's always nice to start with the natural history of disease rather than just jumping in and saying, what do we need to do? Because that can impact what you do and how you do it. So with cervical cancer, we've seen obviously a dramatic decline in the incidence and mortality of the disease in high-income countries. And one of the things that is very important to know about cervical cancer is that it's a slow-growing disease. So the first step is a woman gets infected with a human papillomavirus, for HPV. That in many instances basically resolves itself, but in a very small fraction that can become precancer, and then a subset of those precancers will progress to being cancer. And because very few women actually get disease as a result of having an HPV infection, and because of the time that it takes to actually get the disease, there are plenty of opportunities to intervene. And so the pap smear has been a mainstay to screen regularly for cervical cancer. And the reason to screen regularly is that there is an opportunity to essentially find the cancer, find the disease in case it's missed during one of the screening procedures, right? So the more you screen, the more likely it is that you're going to find the disease. And then the idea here is to screen and then immediately diagnose and treat so you don't lose women to follow up. So in a high income setting, in places like the US, the way that the screening and diagnostic and treatment programs have been organized are to start with a pap smear, and then you look at the smear to find abnormal cells. And if you do, then the next step is to go to colposcopy and biopsy, where the physician looks at the cervix with a low power microscope and then basically identifies places to biopsy. And then the patient comes back again a third time to get treatment, which involves essentially using electric wire to scoop out the diseased area of the cervix, and then that's evaluated by pathology. And of course, now there are vaccines that are being used to vaccinate adolescent boys and girls as a way to essentially prevent cervical cancer in future generations. And so, as I mentioned earlier, there's been a factor of 10 decline in cervical cancer mortality in the last 60 years in places like the US. And we know that in Australia, with vaccination and uptake of vaccination, they're expecting to come close to elimination, which is very exciting. But that has not been translated to low and middle income countries. And what you can see here is that in some instances, the rate of mortality in developing countries is where it was for the US 60 years ago. So there's a significant lag. And also with respect to the vaccine, not only is it not widely available, but 10% of the global female population is already affected by the HPV virus. So these women are not eligible for vaccination. So between the lack of sufficient vaccines and the fact that many women are infected with the HPV virus, vaccination is really going to provide dividends much later in the future, and we need to address this problem acutely. So the WHO came up with some guidelines to basically prioritize elimination of cervical cancer. And one, it's long overdue. This global inequity, when there are clearly solutions in place, is basically injustice. And the second is that, from a very practical economic point of view, the return on investment for every cervical cancer eliminated, considering additional contexts like the job market, family needs, et cetera, the overall picture of what happens if a woman dies. If you account for all of that, the return on investment is about $26 for every dollar spent. And so that is considered one of 4 WHO best buys. And so by doing this, you can really avert not only deaths, but save significant resources, because obviously it's much more expensive to treat advanced cancer. So how does it work in settings where we don't have the same infrastructure or resources needed to implement the organized screening and diagnostic programs that we have in the US? Well, for screening and diagnosis, it's sort of combined in LMICs, where in many countries, the cervix is stained with vinegar to essentially enhance lesions, something that's already done in the US. But rather than having a pulposcope, it's really a headlamp and a provider looking at the cervix and qualitatively making a decision about whether to treat or not treat, rather than having any kind of confirmation. And instead of the loop electroexcision procedure, which essentially ensures that the entire diseased area is removed, the go-to solution is cryotherapy. And not only is cryotherapy has a logistical issue because you need CO2 cylinders that are not always easy to come by, but the depth of ablation is fairly superficial. And so compared to excising the diseased area, the freezing can only kill the first few cell layers, which means that if you have a lesion that is deeper, it will often go untreated. And so therefore you can't really ensure that the woman has been treated. So I mentioned the pap smear, and because we now know about the HPV virus, there are now HPV molecular tests. And what is really exciting about this is it's a molecular test. So either you have the HPV virus or you don't, compared to a pap smear where somebody actually has to look at the cells and determine if there's any abnormality, which is tedious and requires an expert. But there's another important attribute to HPV testing. So on the graph is the cumulative incidence rates of CIN2+, which essentially is a surrogate for cancer development. And on the y-axis, you essentially have time, and in this case, you have several years from the time of perhaps an initial low-grade lesion. And what's important to note is that if someone is HPV negative, there is a very tiny chance that that individual will go on to get cancer, which means that for the majority of women who get an HPV test, the HPV test is going to be negative, and moreover, those women have a very small likelihood of getting cancer compared to the case of cytology, which is why in cytology or pap smears, you have to screen regularly, maybe every 2 to 3 years. Whereas with an HPV test, you could do a single or 2 lifetime screens, and that would really be sufficient to give confidence that a woman is not going to get cancer. The other important piece on the flip side is if you look at the red and blue curves, you do see that for an individual that is HPV positive or cytology positive, not 100% are going to develop precancer, which means that if you don't have something intermediate like colposcopy, then you're clearly overtreating a lot of individuals that don't have disease. And that, basically speaks to the point I made earlier, which is when a less skilled or someone who doesn't have the professional training screens for cervical cancer, if they see something that looks abnormal, they tend to treat it. But in fact, that abnormality may not be disease, but just normal biological variants in cervical tissue. The go-to solution right now, when imaging is not available, is to see and treat, as I mentioned earlier. So while we have LEAP in high-income countries, in low-income situations, we have cryotherapy, and a solution to the need for consumables has been addressed using thermal ablation, and now there are low-cost thermocoagulators that can essentially ablate regions of the cervix that are abnormal. So we have alternate solutions now for screening and treatment, but as I said, because only a small fraction of the women who have HPV need treatment, we absolutely need an intermediate solution to address that problem. So what are the biomedical engineering blocks that are needed to close the gap? And one is obviously diagnostics, as I mentioned. The other is some sort of decision making. And in the absence of an expert provider, we have the opportunity to go to machine learning as a way to address the lack of an expert. And because the cervical cancer care cascade is, involves multiple tiers, communication through telemedicine and mobile apps becomes particularly important. And the nice thing about having a software that does AI and data capture is it can also be a great portal for communication and data storage. So when I was in Tanzania in 2013, I was in a screening clinic at the local hospital, KCMC, and what they had there was a colposcope, just like the one you see here. It was donated. But unlike this colposcope, that colposcope only had a light source that was working. The camera wasn't working. So what they did is they used the light source from the colposcope, and then they took a picture with a digital camera. So they came up with a creative way to solve the problem, but it was not a sustainable way to solve the problem. And so the provider there said to me, can we first develop a solution that can image the cervix with the same quality as a conventional colposcope, but also make it readily amenable to use in places outside of the hospital and make it affordable? And so that inspired the development of the pocket colposcope. And what is distinct about the pocket colposcope is it addresses the very long working distance between the camera on the colposcope and the cervix. And as you can imagine, the longer the distance, the more expensive the camera and the optical components are. If you think about the pocket colposcope as being a device that can be inserted through the speculum, you're able to make it proximal to the cervix and therefore drive down cost and form factor without having to compromise image quality. And that was something that we held as our most critical criterion, that you can't have a subpar image compared to what you might be able to do in a high-income setting. So first, I just wanted to show the technical characteristics of the device and some of the features that are really important. So the comparison here of the pocket colposcope is both in terms of the image quality on the left, and it's qualitative, showing that what you see with the high-end colposcope is captured with the pocket colposcope. But another important point to note is, how do you power this colposcope? And because of its form factor and the way the device is designed, you have a very low electrical power need as well as low optical power. But you're able to maintain the resolution and the field of view. The cervix is approximately 3 centimeters in diameter. So this was very exciting because we were able to lower the requirement for powering the device. It can be powered through a cell phone. And also, obviously, the more the optical power, the more expensive the light sources get. So on the right is a comparison of the images taken with the high-end colposcope and the pocket colposcope. And just for comparison of size, there's not a scale there, but you can think of the LightScan colposcope as being about the height of a person. And it's about 150 pounds. And then the pocket is basically just that. It fits in a pocket, and everything is controlled by the blue part of the probe, and the white part is the functional part of the probe that goes into the vaginal canal. And so there's a stark difference in size, and the pocket colposcope is less than 1/4 of a pound in weight. And then on the right, you can see that you have a normal cervix, a cervix with a low-grade lesion. The arrow points to that low-grade lesion, and then a high-grade lesion. And again, you can see that all of the features, the textural features that are collected or captured with the LightScan are also visible with the pocket colposcope. And many of the solutions that are currently used to get digital images is through a cell phone camera or a smartphone camera. And the challenge with that is that a smartphone is not a dedicated colposcope. It's basically designed for people that used on the cervix. And one of the challenges you have with using any external device, such as a cell phone, is that you get a huge amount of shadow, which means that areas that are diseased can be masked simply by the fact that you don't have light getting there, or they can be clear because there's a speculum in place. And when you're imaging from the outside, you have the challenges of essentially having glare obscure the image that you want to interpret. Now, I mentioned that the colposcope, the pocket colposcope, addresses this issue of bringing an expert device or a high quality device and allows it to retain its features, but to make it accessible in a community setting, which is where see and treat programs are going because of the gap between where women live and where hospitals are. In many instances, these hospitals are geographically out of reach. The second issue is that you need an expert. Telemedicine is one solution, but you can also use machine learning to essentially provide an assistive diagnosis or be the expert in the absence of one. We have used traditional machine learning to develop algorithms in the past on smaller data sets, but since then we've been able to collect more data from the field, and we have moved to deep learning as a way to train our algorithm. So as I mentioned, you do need substantial data from for deep learning. We have 1,000+ images, so certainly not to the extent that we would like. Ideally, we want tens of thousands of images, but that's challenging just given the nature of the resources needed and the time to collect images. But perhaps this is the only portable colposcopy device for which there is this amount of data. Most of the large volumes of data are for cell phones. And so we conducted studies across 4 continents, and we were able to get 1,000+ images from different populations, but also with different screening methods, HPV test, pap smear, or visual inspection with acetic acid with the unaided eye. And so we took all of this data and we asked ourselves, how could we develop a robust algorithm that can achieve performance comparable to or improve upon the performance of excellent trained providers, expert providers. And so one of the things I just wanted to mention is many cell phones only capture white light images. So when you stain with acetic acid, what you see is that these lesions essentially turn whitish. And that's what you're trying to get with an acetic acid white light image. But the problem with that is there are many other conditions where you can see that. So this approach lacks specificity. On the right, you see what is collected with using green light, and green light is specifically sensitive to the vasculature on the cervix, and the vasculature is indicative of high-grade dysplasia or high-grade lesions. And so what we found is with a deep learning algorithm that uses both acetic acid and green light, which is really only something you can capture with a colposcope, we were able to generate receiver operator characteristic curves as shown on the right, where we will be able to get AUCs of close to 0.9 or area under the curve of 0.9, which is something that is better than expert colposcopists. Typically that's around 0.6 to 0.7. And important to note is that you see the green, red, and blue curves. And green only corresponds to green light, red corresponds to acetic acid. And when you combine them, you see that there's a substantial improvement in sensitivity. So for a specificity of about 0.9, you see sensitivity go up from 40% to 80%, which is really significant in terms of the finding precancerous lesions. And we strive to improve this further with different deep learning techniques, such as a class balance function, and also with respect to representing essentially a part of the training, part of the holdout set in the training set as a way to learn representative images from different clinical sites. Because ultimately, when you develop an algorithm, you're not necessarily going to have data from that clinical site. So how many images do you need represented in your training set in order to effectively diagnose in a new population? One other thing that I wanted to mention is that when you do colposcopy in the US, you have to biopsy in order to get confirmation. And there's simply not enough in the way of human resources or infrastructure to do pathology in many of the settings that I'm talking about. And so here is a device developed by my collaborator, Rebecca Richards-Cordom at Rice University. And what it is a microendoscope that can count the density and size of cell nuclei using essentially high resolution microscopy imaging with a stain that's used to highlight nuclei. And so at the top you can see the stained nuclei, and you can see that there are characteristic differences as you go from the left and the right, and you can also see that these correspond to essentially different grades of dysplasia. And basically what this tells you is that you're able to capture the information, whether it's normal or disease, you're able to capture what would be essentially a transverse section, the density and size of nuclei that are present in the tissue. The challenge here, however, is that the area that's viewed by this microendoscope is less than 1 millimeter in diameter. So the idea is, can we use the pocket colposcope as a way to do wide field imaging? And then instead of taking a biopsy to then submit to pathology, could you do in vivo pathology so you can essentially capture all of the information or close to all of the information without ever having to be invasive? So here's just an illustration of that. There's a study ongoing in Brazil with our collaborator. And so the idea is to image the cervix with the pocket colposcope. And then the idea is to do segmentation to identify areas that need to be probed. And we're working on those segmentation algorithms. And then to be able to do the microendoscopy and count the nuclear density as well as quantify the nuclear size by rapidly moving this microendoscope so that we can say, here is what looks like it's diseased. Here is what the actual in vivo pathology shows. And by doing that wide field, high resolution combined imaging, we're hoping to essentially say, how can we address the lack of pathology? How can we address the lack of high-end colposcopy? And how can we address the need for an expert to do the interpretation? Now, is all of this going to happen overnight? No, there are going to be transitional phases, and we think that obviously colposcopy is going to be the most accepted because that's what is used as standard of care. With respect to AI, that's going to go through a transition because it's going to be very hard to convince people that AI is the way to go. So I'm working with NCI to essentially come up with our group and others are working with NCI to come up with a generalizable algorithm that can be used across devices and across sites. And through the support of the NCI, we believe that the impact of AI will be accelerated. And then of course, there's pathology that, is addressed with the HRME, but again, it's a process that is new. So that's going to take probably more time to incorporate. And so the reason I say this is it's very hard to introduce new technologies when they haven't been used before. The pocket colposcope is something that's recognized, and so it's easier to translate. But as you get to more and more sophisticated technologies, one should understand that, in terms of just how people view it, how providers view it, it's not standard of care. And even though in principle it's better, it's an unknown entity, and therefore transitions and adoptions are take longer than would be with the standard of care device. So putting this all together, One of the big challenges with cervical cancer prevention, or for that matter, really any kind of see and treat program, is that you have a model here that's very similar to what is used, for example, in the US, right? So basically what happens is you start at a primary healthcare center, and then you might go for diagnosis at a more specialized facility, let's just say hypothetically a first level hospital. And then for treatment, for example, cancer treatment, you would obviously go to a higher level hospital. So it's this stage process. And the reason it seems to work well, or it has worked well for the majority of population in the US, is that you start with the broad population and then you narrow down the number of people that need to go to subsequent levels of care. And therefore that essentially contains cost. But if you can't make it from the community to the hospital, what do? You try to bring the hospital to the patient. So what we strive to do with all of these technology innovations is not change standard of care, but bring standard of care in different forms to the community, and then show through implementation studies the evidence for policymakers to essentially inform their decisions. And it's hard to convince policymakers to change the way they their guidelines and what they do, but it's easier to stay within the guidelines but make the process more efficient. And so right now, we actually have a collaboration with the former health minister of Peru. And now that there is I don't want to say post-pandemic, but we're in a better phase, they have finally been able to implement on a study that we've planned for 2 years. They are in the Andean region of Peru, in Cajamarca, where I think the incidence of cervical cancer is highest. And they have now essentially put everything into place to show that we can bring all of these tools together. So they have the HPV test. And then when women test positive for HPV, they come to the clinic, they get pocket colposcopy. Currently, there's no algorithm that's being used, but if the physician sees something that's abnormal, they're immediately treated. And so in 2 weeks, they've already screened 400 women for the HPV test, and they've already done colposcopy in about 20 patients. And so you do expect about 10% of the HPV positive patients to essentially have precancer. And so what we're seeing is consistent with that. And so this is essentially a 4,000 patient study. And this is no longer about how good is the technology, but more about, can we actually implement it in the way that we envisioned? And what is the uptake of this procedure over standard of care? And so that's very exciting for us, because at some point you have to move away from an engineering perspective of how good is the technology to say, does it really have any impact? Does it get people to come in and get screened and tested by avoiding the need for them to go through multiple tiers of care? Which can be an opportunity cost for individuals that have families to support and other responsibilities, and taking the time out to go to the hospital would essentially not benefit them if they do put their families first. So we talked about patient-centered design, and there are multiple stakeholders when we talk about patient-centered design. It's not just the women on the ground, it's the providers, it's the program planners, it's the people paying for it, it's the policymakers. So it's really complex. And we have to think about both who are the influencers and who are the people that are going to determine whether something is even taken up or not. Because if there's no one to pay for it, it doesn't matter if it's needed. And so one of the things that we've tried to do is collaborate across different parts of the world with both clinicians and policymakers and funders to understand what drives them, and to also use that information to think about the technologies we develop. Because we think that backcasting is better than developing the technology and then trying to figure out how it's going to fit. Not that we've solved all problems, it's an iterative process, but having academic partners, clinical partners, and industry partners across the globe and cultivating those relationships is what I think leads to sustainable change in terms of impacting the way healthcare is provided. So Originally, this started as a lab with my students and postdocs, but now we have really expanded our effort to not just developing technologies, but seeing them commercialized. And so we have a startup to do that, as well as then working with clinical partners to say, well, we have the technologies, one slice of the problem or solution. How do we then take that to the next step of going from evidence to policy? And that's where implementation science becomes really important. And our collaborators in Peru and Kenya and elsewhere are doing just that. They're doing implementation science because they're really bridging the gap between concept, innovation, and then essentially systems change. And that's where the implementation science becomes really critical, where you can assess the cost of the device, you can assess the effectiveness of the device and acceptance, all of which inform whether something is going to stick or not stick. I want to conclude by just acknowledging a number of organizations that are really putting global health at the forefront. And right now, not only are they funding research, many of these organizations are thinking about how do you get a product commercialized? What is the information you need to do that? How do you essentially prime the technology so that you can get as much done in academia before you essentially go into a company and try to commercialize it? How can you do the implementation science to make sure that the technologies actually achieve impact? And so there are now opportunities for not just doing engineering, but looking at some of those other questions and being able to support that through a diverse number of organizations. So it's a great time to be working on these issues because there's a greater understanding of the different facets of global health innovation that will drive impact. And from a student perspective, I think it's really exciting because they might be engineering students or they might be students in social science, whatever they're in the humanities, they come together and contribute on different parts of the solution, but they also get to learn about solutions that they may not have been trained in or know about. So it's a really great way to start thinking about co-creation, collaboration, not just between engineers and clinicians, but between different disciplines, from policy to business to social science, to look at patient adherence and social acceptance of new paradigms and new solutions. So I think that's a very exciting piece of global health that I think is really impactful to the next generation of innovators. So that's all I have today, and I'd be happy to take any questions if there are any.
So I have two questions. One is actually a pretty quick question. I think on like that third to last slide, when you were showing academic partners, clinics, and then industry partners, so they were color coordinated. There was a little icon on the map that was blue.
That was blue? That wasn't labeled?
Yeah.
Huh.
I didn't know if that was something like different.
Yeah, that's a good question. It could just be a simple omission, or it might be something that I was trying to keep a secret.
Should be near India, I think.
Yeah, academic partner. Yeah.
Okay.
Yeah,
Okay.
Thank you.
Yeah, I wasn't sure if there's any significance there.
No, not at all.
Okay. And then when you were talking about on one of your earlier slides about the HPV test and then pap smear, I think I kind of lost you, at least for that slide. It seems like there would be no reason to use pap smear anymore. So why do people still use it?
Well, I mean, they're moving away. In the US, it's co-testing. But many of the countries you work in still use the pap smear. So it takes a shift to think about how to invest more in HPV testing and less in pap smears, given the challenges. But not every country is doing that. So there's a lot of literature providing evidence to do that. And some organizations are providing the resources to do that. But HPV testing is not ubiquitous. So that's where the evidence comes in. If you can show that there's a benefit, both from a health perspective and economic perspective, then that's going to inform policy, which is why we're doing these implementation studies to show that that is indeed the case.
Okay, yeah, thank you.
Sure.
I just wanted to ask about the something you touched on, which I really appreciated you touching on, which was like the difficulty in translating these big data findings and abilities that are equal or even better than like existing clinical abilities or practices. I've never even thought about exactly like how those sorts of conversations take place, how you begin those conversations with providers. Like this is a big question, I guess, but like, how do you even, or I guess, I should ask, like, what is the biggest challenge? I guess, what's the biggest roadblock you see with providers?
With AI? With providers accepting AI?
Yeah, exactly, yeah.
Trust, obviously, right? How could a machine do better than them? So that's why I think that it cannot be, first of all, you need champions who believe that it can, and influencers, right? Those influencers can, basically, if they have the trust of the constituents, then that's one big step forward. The other is credibility. So working with NCI, they have a moonshot initiative. And in doing that, they're working with really all of the cervical cancer community, stakeholders, researchers, et cetera, industry partners. So that is a big deal, right? Because they're bringing people together and they have credibility globally.
Right.
The third is to not replace one with the other, but system, so that it's a gradual transition. It's kind of like a relationship, and before you get married, and so or whatever. So it takes time, and I think that again, from the perspective of trust, they have to know first of all whether it's equivalent, right? That's the minimum viable product, and if it is equivalent, then that's the evidence, and they have to see how it helps them be better. And it could be also used as a triage tool, right? If it's the first step in screening, and then someone still gets to make the final decision, that's great. So I think it can be different for every scenario, but I think credibility, trust, and evidence of the performance of the technology will be key, but how it's taken up will depend on the country and the influencers or the people who are trying to implement change.
Right. Thank you.
Sure.
I will say very briefly, so in the past, we've had people register for these events, and when you register, we get your emails. So if you are looking to receive notification of when we post this link on our YouTube, or rather the link when we post this recording on our YouTube channel, just fill out that form. Essentially, all we're asking is really for your email, because I know some people on here, I could probably find your emails, but I also don't want to assume that. So just fill that out if you're looking to get a recording. And then while I was doing that, I did think of another question. One of the earlier slides, you were predicting cancer trends, and you were saying that, I think the conclusion you gave is that cancer is generally on the rise, so to speak. I was wondering what data do you take in to make that conclusion? How do you predict that?
Well, one is the registries to see what the incidence and mortality is, right? Right, so that's done by the WHO or GWHT, and I simply just reference that, right? And so it's probably actually, I would argue, worse than we think it is, because not every country has a registry. And so that requires tracking. It's, I think in some ways, easier to look at incidence because people can die for different reasons. It may not be because of the cancer. There's also just access to care, right? If you have a hospital or care facility, you can see how much it's used, or fundamentally what is available. So there's many, I think, surrogates for that, but I don't know what went into the final, number generation process. But I think it's as simple as just adding up the numbers. So the mortality could be skewed just because you don't know necessarily what someone died of unless you had paid specific attention to their care all the way.
Sure, thank you. I know it is 3, so I don't know if we have time for any more questions, but maybe someone has just a real quick question or something of the sort. No? Okay, well, Derek, do you want to wrap us up?
Yes. So I would just like to thank you, Dr. Ramanujam, for giving a really stellar presentation on the research that you present. And I'd also like to give a huge shout out to your assistant, Antonia. She's been the one networking us with coordinating and making sure that the event is happening right now. So I would really like to give my appreciation for that. And I'd also like to give a huge shout out to all of our board members, mainly the people who helped me advertise this event, build the posters. And I'd also like to especially thank our board president, Haley, for transitioning me into being an outreach chair. She's definitely been a really strong mentor, and she's helped me fortify my professional skills in reaching out to our distinguished lecturers. And yeah, if you guys still have further questions for Dr. Ramanujam or any of us on our board, you can always email them to me and our board, and we can get in contact with her to pass on any questions you may have. And you can also visit the website. We'll upload the video to our YouTube channel. And yeah, that's all I have to share.
Yeah, thank you for presenting with us. Really great presentation.
Thank you. Thanks, Haley. Thanks, Derek. Thanks, everyone, for joining. Bye.
Take care.